Good morning to all. So I will be speaking on serum procalcitonin for diagnosis and disease monitoring in fibrolamellar hepatocellular carcinoma. Uh, will be outlined in introduction, clinical presentation, genetic characteristics, histological findings, how procalcitonin changes with the in normal cases, sepsis, and fibrolamellar cancer, diagnosis, disease monitoring, ILBS data, and some new genetic findings with approach. So if I give you one slide that is a fibrolaminar versus hepatocellular carcinoma, laminar means layers. So layers of fibrosis. You can see this slide, then there are layers of fibrosis and intervening are the large hepatocytes, which are eosinophilic granular cytoplasm. That is granular mostly because of the mitochondria. And on the right side, can see that there is a trabecular of hepatocyte that is a classical conventional HCC. There are layers of the HCC only, but there is no fibrosis. But in subsequent slide, it might be become some difficult as there are some serous HCC where the fibrosis can be seen in cases of intrahepatic cholangiocarcinoma. Also, fibrosis can be seen and some endocrine tumors. So incidence is 1 to 9% as per SCER database. Affects the young population, mean age 22 years. There is no gender preference. And WHO classifies it like a well-circumscribed tumor mass with a fibrous stroma, eosinophilic cytoplasmic inclusions, and an absence of cirrhosis or chronic hepatitis. There is no background liver disease. Further, if we differentiate from the HCC to fibrolamellar, so HCC comes in cirrhosis, but there is no cirrhotic. Risk factors are viral or fatty liver. There is no risk factor identified for fibrolamellar. Tumor markers are negative for the fibrolamellar, but it can be positive for the neurotensin, vitamin B12 binding capacities. There is scar of fibrosis, which can be seen in fibrolamellar, but it is absent in conventional HCC. Metastasis is usually to regional lymph nodes in up to 50 to 60% cases, but it is resectable. Driver mutations are DNA JB1, PRKCA, that is a protein kinase mutation, activating mutations. And in the HCC, you can see TP53, CTNNB1, and third promoter. Resectability is limited out of the cause of cirrhosis, and in fibrolamellar, they are very resectable, but there is a high recurrence rate. They respond poorly to systemic therapy, whereas the conventional HCC, we have some FDA-approved immunotherapy. So they present with the stomach pain, weight loss, malaise, and the clinical finding is abdominal mass, hepatomegaly. 60% presents with the metastasis, mostly to the lymph nodes. Two-thirds have regional lymph node metastasis, and 30% are distant lung. Next is adrenal. There is high recurrence rate, 60 to 70%, and median time to recurrence is 10 to 33 months. If we see the survival of fibrolamellar versus normal HCC in the event and in the survival, we can see that non-cirrhotic HCC and fibrolamellar both have comparable and good survival. Whereas in case of cirrhosis HCC and compared with the fibrolamellar, this meta-analysis showed that the risk or event were more in the HCC when compared to the fibrolamellar. But subsequent, when it was compared, fibrolamellar was compared with the non-cirrhotic HCC, they have comparable better, both equal survival. They can have atypical presentation in the form of blood carry because of the compression, level of compressions, level obstruction, severe anemia, hypoglycemia, amyloid deposition, and they can cause biliary obstruction also. They can be associated with carnic complex. Carnic complex is a skin, heart, myxoma, associated malignancy, and they are characteristically associated with PRK protein kinase activating mutations. What are the genetic characteristics? This is a classical 400 kilo base deletion and chromosome 19, which has been seen in all fibrolamellar cancer. This leads to activating DNA JB1, PRKCA chimeric transcript. The associated aneuploidy seen in 50% cases, overexpression of aromatase, mTOR activation, and overexpression of epidermal growth factor, TGF beta, which causes the fibrosis. So for this slide, if you see the first, second name and the last name. So Ilana is a daughter and he is a father. She was diagnosed with fibrolamellar cancer at age of 12. And at age of 15, she decided to sequence her own genome. And at the age of 17, she was successfully identified this DNA JB1 PRKCA mutation, chimeric mutation. And when she was 18, now she is 30. She is doing PhD, and this is with her father. He owned a lab of cellular biophysics where this work was done. So patient himself genome her sequence and identified this mutation, which is still prevalent and still the landmark innovation. So RNA sequencing was performed in the fibrolamellar cancer and confirmed with the RT-PCR and Sanger sequencing. They identified 400 kilobase deletion on chromosome 19, and which leads to predicted a code for the fusion proteins. So this is the location of the 400 kilobase base pairs, and after deletion, these are combined and leads to activation. And this is a promoter protein, and with the help of heat shock protein, this chimera is stabilized, and it leads to further signaling of EGFR beta, MAP kinase pathway, mTOR pathway, W90, and subsequent fibrosis and formation of lamellar fibrosis. But DNA-JB1 or PRKCA1 is not only associated with the fibrolamellar, it can be associated with the intraductal oncolytic papillary neoplasm also, and as well as intraductal papillary mucinous neoplasm. So it should be the patient with the DNA-JB1 should be investigated for the other malignancies as seen with the Carney complex and also with this pancreatic neoplasm. There are other genes apart from the DNA-JB1 which can be seen like protein kind regulatory 1 loss. It is a repressor which subsequently activates the protein kinase A and leads to activating mutations. Loss of function BAP1, that is a BAP1 is a BRCA associated protein. So loss of BAP1 is seen in patients who are negative for the DNA-JB1. So these are exclusive. It can also be seen in the intrahepatic cholangiocarcinoma. PRKCA rearrangement has been seen, and also it has been seen in the papillary neoplasm cases. So if you see on gross examination, fibrolamellar, we need core biopsy, and they are characterized by the pale, yellow to pale tan colored with a consistency that can vary from soft to firm. And central scar is seen in 60 to 70% cases. They can be left lobe predilection, and gross vascular invasion can be seen in 25% cases, and microscopic invasion can be seen in 50 to 60% cases. On histology, there's large polygonal cells, lamellar band of fibrosis, microvascular invasion, and pale bodies. See in this slide, this is a yellow tan paint color. And on the B slide, you can see that these are the fibrosis lamellar layers of fibrosis intervening large polygonal shaped fibrolamellar hepatocytes. On trichome stain, you can see the fibrosis bands, and they are associated with the pale bodies and the hyaline bodies, which can be seen in this slide. On immunohistochemistry, HEPA, that is hepatocyte paraffin, can be positive, like glypican-3 is positive in a small fraction of cases, and they are positive for the cytokeratin 7, 18, 68. But 7 and 68 are very important to decide and demarcate from the normal FCC. So, fibrolamellar or fibrosis can be seen in other malignancies also, like in conventional HCC. In serous variety of HCC, there can be layers of fibrosis. In intrahepatic cholangio, there can be a fibrosis, but has to be differentiated on the basis of arginase and HEPR1. Well-differentiated neuroendocrine tumors are also can have fibrosis, and FNH can have a central scar with the fibrosis, but has to be differentiated with the glutamine synthetase. So if I summarize, then the classical has a HEPR positive, serous variety of HCC have CK7, can have CK7 positive, but fibrolamellar has HEPR1 positive, CK7 positive, and CK68 positive. These three features are required in the IHC to diagnose fibrolamellar cancer on the basis of histology. Cholangio can have CK7 positive, but it has to be differentiated with the other biomarkers. So apart from histology, these IHC markers are important. It can be further seen in this slide, the HEPR positives at CD68 and CK7 in this slide. So what is the procalcitonin in fibrolamellar HCC? So it is a 116 amino acid propeptide precursor of calcitonin. It is encoded by calC1 gene, and it is exclusively secreted by the thyroid C cells in normal individual. Normal level is less than 0.05, undetectable, half-life is short, and in case of normally physiological pathway, The calci-A gene produced by the thyroid C nucleus is causes procalcitonin, pre-procalcitonin, and further it is cleaved to form procalcitonin. And there is a enzymatic cleavage so that procalcitonin converted into calcitonin, N-terminal peptidase, and catechalcin. So in normal patient, you do not find procalcitonin raised because it is cleaved and it is normal. But in case of sepsis, because of the bacterial product like ILPS or gram-negative bacteria, gram-positive, cytokine storm, there is an ectopic production of the procalcitonin in liver, lung, kidney, adipose tissue, and intestinal tissue. And it is called ubiquitous extrathyroidal expression of calci1 gene. So calci1 gene is expressed in other organs, thereby leading to formation of procalcitonin, calcitonin. But apart from thyroid, there is no enzymatic cleavage activity present in other organs. So normally in thyroid, pre-procalcitonin followed by procalcitonin should be cleaved, but in other organs, it is not cleaved and it is increased in the blood. In malignancy, what happens is, like in fibrolamellar carcinoma or pancreatic malignancies, there is either calci1 gene, there's a tumor acquire the neuroendocrine features and they express the calci1 gene, or there's an aberrant signaling because of the altered transcription. When this occurs, so there is a fusion protein formation activating mutations, calci1 activation, and tumor procalcitonin synthesis. There is no infection, but the procalcitonin raised because of the ectopic tumor production or altered transcription leading to fusion chimeric transcription activating mutation of protein kinase A. So in case of fibrolamellar, these are the two, but in case of pancreatic malignancy also, it can be positive because of the ectopic neuroendocrine-like features. So there is a fusion kinase activation, CRP transcription, ectopic calci1 expression, and PCP secretion, which leads to clinical detection of procalcitonin in fibrolamellar cancers. So the foundation of this major study, which will be coming, is led by this study, that is a case report in 2021, in which they diagnosed a 37-year-old male with the fibrolamellar cancer, and they showed that the procalcitonin was very high, and it did not come out with the antibiotics. Cultures were negative, but they operated that case, and post-operatively, procalcitonin decreased. So they reported it as a high procalcitonin in mixed fibrolamellar cancer. Subsequently, this study, which is recently published, current issue, June 2026. In this study, the serum procalcitonin was measured in 34 samples from 18 patients of fibrolamellar cancers, and they have compared it with the further from cholangio, from FCC, and cirrhosis patients. RNA sequencing was performed, and PCT immunohistochemistry was also done. So these were the baseline parameters of these fibrolamellar cancers. So there was only 8 patients in European cohort, and United States cohort, there was 10 patients, total 18 patients. And mean age was comparable 20-23 years in both groups. So if you see in this left side, the European cohort, the procalcitonin was measured in the fibrolamellar cases, and the mean value was around 54, 55 for this European cohort. It was in microgram per liter. In USA cohort, the mean value was slightly higher, around 160, and this was in USA cohort. And in this, you can see that procalcitonin was increased in the European or USA cohort in the fibrolamellar cases as compared to the normal cases. The sensitivity was 83% and specificity was 97%. But in ILBS, I'll coming to that data. So 267 for the USA cohort, and the median PCT for the European cohort was 55. Then they further checked it with the response to treatment. So in patients who has a progressive disease, procalcitonin was rising. In patients who had stable disease, it decreased to low down, and in patients who had responded or given the peptide vaccines along with the immunotherapy, this patient received nivolumab with ipilimumab and a peptide vaccine, and the procalcitonin was dramatically decreased. This peptide vaccine trial is still undergoing with this NCT. So, and Then they checked whether procalcitonin is expressed by the calci-A gene. So they found that calci, uh, calci-A gene was overexpressed in patient with fibrolamellar cancer. So that is the reason that this gene is overexpressed in fibrolamellar and the procalcitonin was high. So then they identified with the DNA JB1 mutations whether it is related to the mutation. So they showed that the patient who has a DNA JB1 mutation, they had a high procalcitonin as compared to the patient who has negative DNA JB1 mutation. So the mutated DNA JB1 mutated patients will have high procalcitonin as compared to the patient who did not have these mutations. Then the letter to editor was also sent to this study from the Germany, and they also validated that they also found that procalcitonin in their cohort was also changing with the treatment, responding, decreasing with the treatment, and increasing when the disease was progressive, and stable when it was normal. So in another study from the Turkey, this procalcitonin, they also showed that they validated the same data. So if we talk about the ILPS data, we have around 7 cases of uh, fibrolamellar cancers, and we have explanatory and biopsy, and mainly they were pediatric and young adults. So this work has been done by the Vanya, and the slides have been provided to me by Dr. Gayatri ma'am. Thank you. And she performed the thick section analysis and isolated the DNA and done the PCR and Sanger sequencing. And this showed that the DNA JB1 and PRKCA mutations was also positive in our 2 patients, case 1 and case 2. But in the case 3, she found that another mutation was positive, that is a BAP1. BAP1 is BRCA associated protein. It is usually positive in cases where the DNA JB1 mutation is negative. So this is exclusive to DNA JB1 mutations, and BRCA associated protein is usually a tumor suppressor gene and causes DNA damage repair, but the mutated causes the fibrolamellar cancer. So procalcitonin was also measured in our cohort of fibrolamellar cases, and it was raised, but not at raised as seen in European cohort of the same nanogram per milliliter. So in our cohort, it was mostly around 6 to 7, and some with the metastasis has a very high procalcitonin, but it was not that high, where in the European cohort it was 55, and in the USA cohort it was 267, but 267 was the picogram, and this is nanogram. Next, we did analysis by the TCGA database, and up till now we have seen that the DNA JB1 mutations is positive, but on the TCGA database analysis, we found that oncoprotein sarcoglycan zeta, which is responsible for the cytoskeletal integrity mechanotransduction, is altered in 33% cases. Also, zinc finger protein has been altered in 33% cases, and it is a transcriptional repressor. ADAMTS13, you can see the some types of ADAMTS. Proteases regulate the extracellular matrix remodeling, and this has been found on the first time that these proteins were changed. Next, with the pathway analysis, and we found that genomic integrity was the most frequently affected pathway, which is seen in these genome, and very important, MAP kinase signaling was found also to be affected. MAP signaling represent one of the few shared oncogenic vulnerability between the fibrolamellar and conventional activities. So apart from DNA JB1, first time we can say that genomic integrity is also involved, and MAP kinase signaling is also involved in this fibrolamellar cases. Cosmic signature analysis was also done for these patients, TCGA database patients, and we identified that it is an endogenous age-related mutational process that sir, we have control in our ILBS cohort also,
No,
and this
any HCC patients you have taken as a control to see, these are only FLH. Anyway, go ahead.
So cosmic signature analysis was also done, and it found that mutational signature analysis revealed that SB5 and SBS40 associated signatures were mostly associated with the endogenous age-related mutational process rather than environmental changes. So it further strengthened that it is the genomic instability and not environmental modification which is causing the fibrolamellar cancer as compared to the conventional HCC. So to conclude, DNA-JB1 protein kinase A driven signaling impacts clinical outcome prediction in fibrolamellar cancers. The patient who have positive or mutated DNA-JB1 have a high procalcitonin. Patient who was negative usually doesn't have high procalcitonin. Procalcitonin elevation in fibrolamellar cancer occurs independently of bacterial infections, highlighting the importance of considering tumor-related PCP production. And it directly produces procalcitonin through aberrant calci1 gene activating mutations and the rearrangement mutations of the protein kinase A. BAP1 mutation and protein kinase A rearrangement mutation in fibrolamellar cancer are independent of DNA-JB1 chimeric mutations. If we approach these fibrolamellar cancers, then the patients coming to us with a young age and absence of liver disease, we do histology, find out the morphology in the form of polygonal, large cytoplasmic inclusions with the layers of fibrosis. There are prominent large nuclei. Hepatocellular phenotype can be differentiated on the basis of arginase or HEPAR1. If it is positive, then we proceed further. If negative, then we have to exclude with the neuroendocrine or pancreatic cancer, cystic neoplasm. We confirm with the molecular DNA JB1 mutations or loss of ERK1 mutations of protein kinase A. If they are positive, then fibrolamellar. If negative, then we have to exclude these cases. Way forward is no staging of fibrolamellar cancer has been there, so some can come up with the proposal. That's all. Thank you.
Nice work. There is one recent fibrolamellar. I think we have referred to surgery. My two comments is the lower procalcitonin could be age related because the patients who were in the Western cohort probably were 18, 20 and above, and ours are younger except the last patient. So I want your comments and thoughts on that. And what is the incidence of focal vein thrombosis?
So first question second question first. That incidence of focal vein thrombosis macrovascular is around 25 to 50%. Microvascular invasion is around 50 to 60%, very high. And with the age, so DNA JB1 mutations has been seen in the younger age group. Older age group usually do not have this kind of mutations. Also, recently we had seen one 70-year-old patient who had normal procalcitonin, and probably he is negative for the DNA JB1 mutation, which we have not done till now. Maybe patient goes to surgery. We need 4 biopsy material, not fine needle biopsy. So 4 biopsies needed to confirm the diagnosis, which we rarely have.
Any other comments? Things of pathologist Archana or any comment? Sorry?
There are 4 patients whom we have treated with radiation therapy, followed by chemotherapy and immunotherapy with nivolumab. So of these, all the 4 patients, when we have started with radiation therapy, they were metastatic. And in one of the patients, procalcitonin was negative at the time of surgery, but when she developed metastasis, procalcitonin increased. So that can be a marker for progression of disease as well. We have seen that many patients are responding to gem oxaliplatin along with nivolumab.
Surgery still remains, and recurrence after surgery again is a challenge.
60 to 70% recurrence rate is there.
We can operate, but they do come back. Okay. Thank you. Very nice.
A very good morning, everybody. So today I'm going to be talking about the effect of ketogenic and the non-ketogenic weight loss diets on hepatic steatosis and mitochondrial metabolism in mast cell. So over the next few minutes, we shall be discussing about the composition of ketogenic diets, the mechanism of action in mast cell. We'll discuss the animal and the human studies on these diets and also see the potential risks involved with ketogenic diets. Well, it is well known that a higher amount of weight loss is not only associated with hepatic steatosis reduction, but it also helps in achieving resolution of active inflammation and regression of fibrosis. And this holds true even in the present times of emerging pharmacotherapy in mast cell. And so weight loss and physical activity are the first line of treatment in mast cell. So the guidelines are talking about the reduction of calories and increasing the physical activity and targeting at least a 7 to 10% of weight loss in these individuals with mast cells. However, there is no consensus on the macronutrient distribution and the type of diet that can cater to these targets in patients with mast cell. So thus we are left in a state of confusion as to which is the best diet for patients with mast cell. Now, these are the different dietary approaches which are based on the macronutrient distribution. On the extreme end, we have the ketogenic diet, which has a calorie distribution of around 75 to 80% of the calories coming from fats, the remaining from proteins, and very low amount of carbohydrates. But the non-ketogenic diets are mostly, the most popular ones are the Mediterranean diet, the DASH diet, the low-carb, high-protein diet, the low-carb, high-fat diet, and even the low-fat diet, which plays around with the percentage distribution of the different macronutrients, anywhere ranging between 10% to 30% for proteins, between 20% to 70% for carbohydrates, and between 15% to 40% for fats. So if this is the breakfast plate that how looks like for the standard weight loss diet, we can see that it provides almost 50% of the calories are coming from the carbohydrates, that is almost 200 grams of carbohydrates, a very good amount of protein, and remaining calories are coming from fats. Whereas in a standard ketogenic diet, we see that the carbohydrates are reduced to less than 50% and here around 5%, providing only 20 grams of carbohydrates, a good amount of protein, and the maximum amount of calories are coming from fats, that is 75%. So that means these diets are classically, they are removing all the high carbohydrate and even the moderately rich food items that are rich in carbohydrates, leaving on the plate only the meat, the eggs, the full cream dairy, some vegetables, very few amount of protein, specific ones like avocado, nuts, and the fats, the butter, lard, ghee, and extra virgin olive oil. There are a number of variants of the ketogenic diet. We have the very low version, the low calorie version, which is the very low calorie ketogenic diet. It focuses on the reduction of calories to less than 800 kilocalories per day. The Mediterranean version of it prioritizes on the use of the monounsaturated fatty acids, focusing on the olive oil, fish, and nuts, and the modified Atkins diet, which keeps the carbohydrate at a low percentage, but does not have any upper limit for the total number of calories or the proteins. So now let us look at the pathophysiology of the hepatic lipid accumulation, which is nothing but an imbalance between the input and the disposal of the free fatty acids, where the majority of these fatty acids are coming from the subcutaneous adipose tissue. 15% are contributed by the dietary fat, and the remaining 30% are coming from the non-lipid dietary precursors through the de novo lipogenesis. And all this is in the background of insulin resistance and a highly pro-inflammatory milieu. Now, what a ketogenic diet does is that it capitalizes on the differences in the insulin response to the various macronutrients, where the insulin we know is the primary anabolic hormone. So a ketogenic diet, which is very low in carbohydrate, it marks a starvation response. It alters the blood glucose kinetics. It increases the pancreatic beta cell signaling, ultimately decreasing the insulin concentration. And this increases adipolysis, unlocks the adipose tissue as the fuel, increases the free fatty acids, and where the body fat is being used as the primary source of energy and helping in reducing the body weight. It also increases glycogenolysis in the muscle and the liver, causing significant water loss. As we know that 1 gram of glycogen takes along with it 3 grams of water molecule. It also increases gluconeogenesis, causing the breakdown of the muscle protein, because in this ketogenic diet, it is important that the blood sugar has to remain in the physiological range, and that is called as the controlled physiological ketosis. The high protein and the high fat content of a ketogenic diet increases satiety, and the ketone bodies, which I'm going to show, which are produced, they are also per se, they increase the satiety and impact the body weight. Ketogenic diet have a major role to play in bringing down the intrahepatic triglyceride contents. As the insulin concentrations increase, the glucagon and the insulin ratio goes skyrocketing. The absence of glucose kind of has a metabolic impact and a stressor impact and stimulates the catecholamines. It increases the master ligase, that is the adipose triglyceride lipase, and causes the hepatic lipolysis with an aggressive mobilization of the stored intrahepatic triglycerides, and that's bringing down the liver fat content. Now, the ketogenic diet, they alter the blood glucose kinetics, increase the glycogenolysis, and when all the stores of the body, they are depleted, the insufficient glucose is not enough to sustain the energy needs of the central nervous system and to sustain the fat oxidation. The oxaloacetate is redirected towards the gluconeogenesis. Because of insufficient pyruvate and oxaloacetate, the acetyl coenzyme A actually cannot enter the TCA cycle. It accumulates in the mitochondrial matrix. There is a TCA cycle break, and excess acetyl coenzyme A is partitioned into the formation of ketone bodies, and mainly the acetoacetate, which is later on converted into the beta hydroxybutyrate and acetone. So this way, all the liver fat on the body fat is actually transported out for the use of the peripheral organs. Now, another place where the ketogenic diet has an impact is the de novo lipogenesis. The ketogenic diet, because of the low carbohydrate content, the glucose-derived pyruvate is less. The hepatic cytoplasmic pool of citrate, which is the main precursor of the fatty acid, that decreases, and so the lipogenesis, de novo lipogenesis decreases. The ketogenic diet, because of the altered insulin and the glucagon ratio, it kind of suppresses the SREBP expression, which is the master transcription factor for the lipogenic genes. It alters the key rate-limiting enzymes of the de novo lipogenesis, the ACC and the fatty acid synthetase, which links the glycolysis to the fat synthesis. And the low glucose kind of also suppresses the malonyl coenzyme A, which acts like a malonyl switch, the malonyl, which is a substrate for the chain elongation for the fatty acids. So when this malonyl decreases, it lifts up the allosteric inhibition of the CPT, the carnitine palmitoyl transferase, thus clearing the entry gates for the mitochondria so that the fatty acids can get inside to be oxidized. And you can appreciate it here, this malonyl switch, where this malonyl, which is usually kind of blocking the CPT, but when you lift up this inhibition, the long chain fatty acids are easily transported inside the mitochondria. So what the ketogenic diet is doing is actually, it is inhibiting the de novo lipogenesis at multiple levels. It has an impact on the pyruvate. It kind of suppresses the fuel pathway, the filler pathway, that is also the anaplerotic pathway, and suppresses the TCA cycle. When the TCA cycle is suppressed, the citrate output is also suppressed, which is the main building block. The malonyl coenzyme A is suppressed, and so the enzymes which facilitate the lipogenesis and bringing a shutdown to the de novo lipogenesis completely. And maybe this is the reason why there is we see a rapid liver fat reduction, as in this study, which was published in Gastroenterology in 2009, where 22 patients, obese patients with NAFLD, it was done in 2 phases, when the ketogenic diet was compared with the high carbohydrate diet, and they found a 30% reduction in the liver fat with the ketogenic diet as compared to only 9% in the non-ketogenic group within 48 hours. Now, apart from these independent these roles, the ketone bodies per se have independent roles on the fat oxidation, insulin resistance, and the mitochondrial health. The ketone bodies, they apart from the malonyl switch, the ketone body per se has an impact on the CPT, and it kind of decreases the blockage and increases the transportation of the free fatty acids into the mitochondria and increases beta oxidation. It has an independent role on the insulin resistance, where because of the increase in transportation, the cytosolic accumulation and the toxic ceramide buildup is reduced, which increases the phosphorylation of IRS1 and thus increasing its functionality. Through AMPK and SIRT1, it increases mitochondrial cleanup and mitophagy and biogenesis, decreases the diacylglycerides, and also increases the functionality. The ketone bodies per se, they bring about an epigenetic unfolding of IRS1. They suppress the signaling cascade that produce the pro-inflammatory cytokines, and all these effects of ketone bodies are independent of weight loss. The ketone bodies also improve the overall mitochondrial health through they reduce the histone deacetylase and activate the PPAR alpha and increase the fatty acid oxidation. They suppress the fission and the fusion of the mitochondria, causing mitochondrial remodeling, and mitochondrial biogenesis is promoted. Also through PGC1 alpha, they also increase the mitophagy and decrease the mitochondrial dysfunction through various mechanisms by upregulating the key proteins of fatty acid oxidation and the TCA cycle. They again improve the mitochondrial dysfunction. And through various direct and indirect mechanisms, they block the inflammasomes, and the mitochondrial oxidative stress is being taken care, thereby improving the overall mitochondrial health. So we see that what are the main drivers of the clinical benefit of ketogenic diet is first is the absence of carbohydrates. When we consume a high carbohydrate diet, along with insulin resistance, it keeps on converting it into the fresh fatty acids. And when we consume less amount of carbohydrates, the de novo lipogenesis is totally cut off. We have to ensure the ketosis because all the incoming acetyl coenzyme A is heavily partitioned into the formation of ketone bodies, which are used by the peripheral organs like the muscles, the central nervous system, and the heart. And being in a calorie deficient state is something which is very important. The energy demanding peripheral tissues, they pull the ketones from the liver while the liver is making it from the fat. So what we see here is that the difference between in the hepatic metabolism, where it is making a difference, is that when in the regular diets or the non-ketogenic diet, when the hepatic insulin is moderately decreasing, it is massively crashing in the ketogenic diet. The glucose, there is a steady endogenous glucose production going on in this, but the liver fully shifts to gluconeogenesis in a ketogenic diet. The hormonal milieu is moderately elevated, where it is markedly elevated here. The fate of the fatty acids is that it is strictly oxidized via TCA cycle, but here it is converted into ketone bodies. And there is a steady TCA cycle. However, it is suppressed here. The de novo lipogenesis gradually reduces. Here it is abruptly suppressed. The intrahepatic triglycerides, they drop linearly and gradually over months and weeks, depending upon the total peripheral adipose tissue which is being lost. But here there is an ultra rapid, sometimes it is seen, as we will see in the later studies, is that it is independent even of the weight loss. The weight reduction is gradual here, but it is faster because of the glycogen loss also and satiety. The mitochondrial redox state is stabilized here, but here it is increased because the NAD-NAD ratio is totally increased. So there is a potential risk of liver injury with the ketogenic diet, as we see when the fatty acid oxidation increases, there is an increased production of the NADH, which increases the NADH to NAD plus ratio. This is a highly redox state in the mitochondria, a state of energy abundance and mitochondrial backup. This kind of decreases the beta oxidation of fatty acids. It causes the flooding of the mitochondrial complexes 1 and 2, leading to the leaky mitochondria, leaking of the reactive oxygen species and the mitochondrial decay. It arrests, this mechanism per se arrests the TCH cycle. It can inactivate the NAD-dependent mitochondrial sirtuins, thus compromising the antioxidant defense and the mitochondrial health, which can lead to progressive liver injury and advanced MASL. So let us look at the animal studies. Well, there are a number of animal studies that have been done so far, but here in this slide, I'm taking only a few recently done animal studies where we see most of them have shown a reduction in the steatosis, the mitochondrial fission, the dysfunction, the weight loss, and the insulin secretion, which has shown a beneficial effect with the ketogenic diet. However, the long-term effects of these diets, with time, these differences actually disappear. The dyslipidemia, hepatic steatosis, glucose intolerance increases, steatosis increases, the cytokines level increase, the hepatic insulin resistance also increases, and inflammation, and so does the severe liver injury. But if we look at the human studies now, the initial studies, say from 2006 to 2020, they were done most of them were done in the obese population of NAFLD and also in individuals who were undergoing bariatric surgery. The numbers were quite less. They didn't much bother about the calories coming from the ketogenic diet, so they used the Mediterranean version and the calorie unrestricted diet also. There were no control groups, and the duration of intervention was a little longer, say from 3 months to 6 months. They all showed a reduction in the body weight, reduction in the body fat, and also the liver fat, whether it was measured by CT or by ultrasound. However, they were also trend towards reduction in the fibrosis in these studies. Now, if we look at the later studies, we see that they are also done in obese patients with NAFLD. Now, the numbers have increased, and this time now, the ketogenic diets, they are moving towards the very low calorie ketogenic diet, which is very popular. The duration of intervention is now little lesser, it's shorter duration, from 6 days to 1.5 or maximum of 2 months. Again, there are no control diets. There is a reduction in the body weight, the body fat, and the liver fat. But there were some studies which show an improvement in the metabolic markers, while the others do not. And they also show a gender-specific clinical approach where the differences in genders. So, but if we look at the RCTs, there are very few RCTs on the ketogenic diet in MASLD. They are all done in obese patients and with a relatively good number and using a low calorie or a carbo or calorie restricted ketogenic diet in all these studies, and moving from commercial formulas to home delivered meals, even to ketone supplements. They have a control group which is eucaloric in nature and providing good amount of carbohydrates. The duration of intervention ranges from 14 days to 3 months. Some studies did find a reduction in the body weight while the others did not. Likewise, the body fat also reduced, but in some it did not. The intrahepatic fat reductions that were seen in the initial 48 hours, they actually disappeared with the long-term administration, and there were no changes in the fibrosis. But this one study, which was published in 2026 by Kadri et al. Now, it is recently published in JHEP, and this is a crossover design comparative study where 10 individuals with a high amount of intrahepatic triglyceride levels, they were given ketogenic diet for 6 days with a washout period of almost 858 days apart. They were given the non-ketogenic diet. The diets, they were the same as we talked earlier, 6% of carbohydrates in the ketogenic diet and 42% in the non-ketogenic diet. And the calories were 70 to 75% of the habitual energy intake. The forte of this study is that they used state-of-the-art technology and methodology for imaging MRS, MRE, and for the metabolic markers, where it was studied by the isotope tracer methodology, the NMR and the LCMS and the PINTA methods. And they have analyzed all the metabolic markers that we've discussed, important ones that we've discussed so far. So what they found was that the difference in the weight loss was not much between the groups. Maybe they are attributing it to the glycogen loss and the water loss. The difference in the percentage of body fat reduction is also not different between the groups, but with time, yes, it is better in the ketogenic group. The intrahepatic triglycerides are highly reduced in the ketogenic diet, where it brings about a 46% reduction as compared to the non-ketogenic diet. The liver stiffness remains unchanged. There is a threefold reduction in the plasma glucose and the serum insulin levels. And there is a high NEFA value, implying that there is an uninhibited adipose tissue lipolysis. The ketone bodies increased, though they increased in the non-ketogenic group also, but here 6 to 9-fold increase. The adipose tissue resistance remains unchanged. And that means that all the benefits in the the improvement in the insulin resistance during the short period of 6 days, they are confined to the liver, where the liver insulin resistance is almost, the improvement is almost 3-fold higher as compared to the non-ketogenic group. So what we see here is that the hepatic TCA oxidation, it decreases significantly in the ketogenic diet group. The redox state, whether it is the hepatic mitochondrial redox state or the whole body cytosolic redox state, it is all highly increased, implying that it is the mitochondria is in the overwhelmed state. It is highly reduced state. The circulating metabolites, what we see is that the acetyl-carnitine, it is highly increased in this group, which actually means that it has the potential to suppress the beta oxidation through the CPT1, which the malonyl switch had actually opened. And the glucogenic amino acids, we see that there is an increase in the branch chain amino acids. That means a greater oxidation of the branch chain amino acids is seen with the ketogenic diet. So they conclude that these authors at the hypocaloric ketogenic and the non-ketogenic diet, they were both highly effective at ameliorating their MASLD and improving the insulin resistance within just a period of 6 days. The effects are more pronounced, though, in the ketogenic diet, reflecting that it pushes the body into a state of starvation. However, these benefits are accompanied by the suppression of the hepatic mitochondrial TCA oxidation and increase in the redox state. These features, which are previously linked even in the animal studies with the progressive liver injury, and such ketogenic diet-mediated changes could potentially be harmful for the individual with advanced MASLD. Now, apart from this, there are a number of systemic effects that have been described with the ketogenic diet. It can cause ketogenic flu, though it subsides within a few days. It can cause gastrointestinal issues because of the total avoidance of legumes, the short-chain fatty acids, fruits. The gut microbiome goes for a toss. There is severe constipation. There can be a gallstone formation, especially in individuals who have a pre-existing high cholesterol levels and a history of gallstones. The cardiovascular risk, though it routinely lowers the triglyceride, but its effect on the LDL cholesterol and the ApoB, which is the main driver for the arterial plaque formation, is kind of inconclusive. It can increase the skeletal muscle loss is another issue, which reduces the anabolic signaling of insulin, and the gluconeogenesis causes the muscle protein to be lost. The bone health also goes for a toss because of the increased calcium excretion because of the acidic nature, and it helps in the formation of kidney stones. So this is an interesting study which is published in Lancet in 2018, which was where 15,000 American men and women were studied over 25 years. And it shows the percentage of calories coming from carbohydrates and the longevity, which we see that too high and too low of carbohydrates actually reduce the projected longevity compared to a standard intake of 50 to 55%. And so the level of evidence on the various dietary modalities that are used in MASLD is that when the Mediterranean low fat and the low carbohydrate diet, they are well reported with RCTs and they are accepted by the guidelines. The supporting evidence for the ketogenic diet is not enough, and it is only for the short duration, and no clinical practice guidelines explicitly recommend this diet. So I would like to sum up that nutrition is the bedrock for medical management in MASIL. The importance of weight loss cannot be overemphasized. Ketogenic diet is a high fat, low carbohydrate, and a high protein diet with complex mechanisms of actions. It hugely affects the mitochondrial metabolism in multiple ways. The short-term use results in rapid reduction of liver fat and improvement in insulin resistance, especially the hepatic insulin resistance. But the long-term use is questionable, especially with a pre-existing liver disease. It is not free from risks and warrants careful implementation. And so the best diet is a balanced diet.
Very nice, Jaya. Can you go back? Very calm. You have mentioned, not this, the last one. Summary. Now you have mentioned ketogenic diet is a high fat. So what is the type of fat? On one of your slides, you said it is the saturated fat. So is it saturated or it is unsaturated fat?
Just a minute. So it's mostly the saturated, along with olive oil, if we use as the unsaturated ones.
Oh.
Why? Because
The picture of the mitochondria, we
Yeah.
show the mitochondrial picture. The mitochondrial picture shows that you have a saturated fat getting into the mitochondria. Yeah, this is the one. So if you have saturated long chain, so all these are long chain fatty acids coming in. Is that correct, or which type of fatty acid?
let's say the ketogenic diet is the Western, it is not being practiced here, especially in MASL in India. But yes, if we talk of the Western literature, the most oils, what they are using and recommending
C18,
is
C20, C24.
yes, it's the
So
long chain,
long chain. So there will be C18, about stearic 16 and above. That's one. And so I wanted your clarification because that is one of the disadvantages. And second, is it high protein or 10% protein? Because ketogenic can be two types: ketogenic with high protein, ketogenic with standard protein. So I thought it was 10 to 15%
it's
protein.
20% protein. So predominantly, as I showed you on the
It's about 10% ketogenic, but you can correct me on that.
it's 15 to 20%, even going up to 20 to 25% with the Mediterranean version, and even 30% with the modified Atkins version. So that means it will always be, the proteins will always predominate, and because the remaining would be the fats and very low carbohydrates. So in any case, to keep the total to 100, when you're bringing down the carbohydrates, increasing the fats, the proteins will compensate for the remaining calories.
Proteins will also convert into glucose by gluconeogenesis. So, but the fats will not convert into gluconeogenesis. So that is why protein is lower, not high. If you have 20% protein, it might convert into glucose. These are my thoughts, but we stand to correct it. Any other comments? Well, very educative. Thank you, Jaya. Very good.
Thank you, sir.
We have an important day today. Please keep sitting. And we have new people who have appeared for the exams, and on behalf of the whole faculty and the students, we welcome all those who appeared for the PDCC exams. I guess all of you are here today for your Viva and for your interactions. So we welcome you to the ILBS fraternity. Thank you for considering ILBS as a destination. And I would like our controller exams, Professor Amar, to tell you about the plans for the day.
So good morning and welcome all. First of all, I would thank everybody for considering ILBS, and congratulations to all who made it. So we'll be having departmental assessment today for the selected candidates, and you will be guided to different departments by the academic cell. And thereafter, after completing your